And so if you're familiar with FQHCs and kind of the work that FQHCs do, just to give some context, that last year, 32% of our total visits, that includes primary care, were behavioral health and SUD services. So it's a big part of what we do in the context of the work that we're doing in integrated behavioral health. I wanted to share a little bit of data. Well, first of all, I don't know if we can do virtual hands or real hands, or familiar with sort of the FQHC model. Yes, I know what no, yes. Okay, well, just briefly, federally qualified health centers, they're, federally, with federal dollars supported to provide primary care services and other supportive health services to individuals that are either on Medicaid, for in California, Medi-Cal, or are uninsured. So there are health centers everywhere across California, and with the expansion of the Affordable Care Act, health centers have really expanded the scope of what they do. And so I just wanted to give you some sense from state data that came from California Primary Care Association about what FQHCs are doing. So 100% of FQHCs in California are providing primary care services. Of course, you have to provide, to be an FQHC, you have to provide primary care services. And something unique to being an FQHC is that we do not turn anyone away based on their inability to pay. So if someone is uninsured or can't get access to Medi-Cal, that they would be offered a sliding fee scale, and we would not turn them away for that visit either, even if they weren't able to pay the fee at that time. So that's the context to kind of what the work we do. And then another unique requirement for FQHCs is that at least 51% of our board, so a majority board, must be consumer board members of our services. So people that are active consumers of our services to provide input and engagement into the work that we do. 96% provide dental care. So that's also a big part of what we do. 96% provide behavioral health services. That's integrated mild to moderate mental health services that are embedded in primary care. This, just for some context for this, because 96 seemed like a lot to me. So I dug a little bit about the data. I was like, that can't be, that's amazing, right? So if a health center provides integrated behavioral health at any of their sites, it's considered yes to that. So it may be like, for us, we have multiple sites, but not every single one of our sites provides integrated behavioral health. So just to give you a little bit of context to that. And then 65% are providing medication-assisted treatment, so evidence-based medications for individuals that are using opioids. And that's gone up quite a bit over the years. FQHCs have been really a part of that. And then specialty mental health, that's all the contracted mental health services that the county, typically with kids, adults too, that only 35% do that. And then drug Medi-Cal, which is the Medi-Cal benefit for individuals that need substance use treatment, it's only 24%. And so I'm going to talk a little bit about why that is and some of the challenges with that. So integration and access, I just wanted, whether it's obvious or not, that these two topics are so intertwined together. I don't think we can have true access unless we have integration of services. So we could look at primary care in a silo and say, oh, we have great access, right? But if that person entering primary care doesn't have direct access to other services they need, it's a real problem. So to me, they go hand in hand. They're intertwined. We can't talk about one without the other, because I think I feel like we're solving for the wrong problem if we just focus on access to one service. We really need to broaden and think about how people navigate all these very complicated health systems that we may have personal experiences with as well. So I just wanted to first kind of open up. I have opinions about this and I will share them, but I wanted to open it up to you all first to reflect on integration and access and think about like what is working well. Like, what do you think are some positive things that are coming out of the work that's happening? And CalAIM was, is not fully realized, of course, yet. That was talking about health centers or the work that you're doing. Like, what's working well? And you can either chat it in or unmute and share just a few sentences. What comes to mind? Does that mean nothing? Does that mean no one can think of anything?
Hi, this is Joe Monroe. I can't turn my camera on because I have my son. So if you hear him in the background, that's him yelling at me to read to him. But I'm a second year student at Sac State. And I think one of the things that is working for us as students is um, the level of training that we're receiving in our program. I think is really preparing us to, once we graduate and enter the field, to um, be successful and positive in the field of mental health. So from our perspective as a student, or my perspective, I think that's one of the positives that is working for us.
That's great. And we host a number of interns from local universities that are receiving their masters. And what I hear is that there's a lot more focus on integration, like thinking about integrated settings and how integration can happen. So I hope that reflects what you're experiencing, Joe. Thank you for that. Are there other thoughts that come to mind, or just thinking about our mental health or substance use systems? Like anything you feel like jumps out at you that's going well?
Hi, good
Hi,
morning. My
morning.
name is Mireya. I work at a substance use clinic. I just started there, but I've got 3 years in the mental health side. And we're in the same building. And I think the collaboration between both of us is going really well, between clinicians, case managers, and everybody. So I think it's convenient for us that we're in the same building. But other than that, I think it's really, the communication is really well,
That's awesome to
really
hear.
good right now.
Great, great. Okay, thank you. So I'll share a little bit from my perspective, and if thoughts come to mind, please interrupt. I have little kids at home, so I'm used to being interrupted constantly, so feel free to just jump out, and I'm flexible in that way. But I want to first say that I think there is finally a realization that the behavioral health is healthcare. Like, I think we're finally at there, that we realize that the head is part of the body, and that when we're thinking about taking care of a whole person, we're thinking about behavioral health and substance use. I think we're there philosophically. Not everybody, but I think we're as a field. Now, how we do that and how we achieve that, I think, is more of the challenge that's happening, and I'll reflect on that a little bit later. But for the FQHC model specifically, I think having services, and counties can do this too, but having services under one roof is important, right? Our systems are so complicated. How to access, mental health services, substance use is so challenging. And it's challenging even if things are going well in your life. If you have resources and you know how you can sit on you have the privilege of being able to stay on the phone, or privilege of transportation, a language, there's so many ways in which that our systems are set up as barriers for people to get access to care. So a lot of the FQHC models, counties do this too, is that services are under one roof. So it might be different ways to access it, but they're there together. So someone can go for Communicare, the site that I'm at right now, someone can walk in for dental, primary care, behavioral health, or substance use treatment, and perinatal services, and get it right here at the same address. And so that means, to the reflection that just happened, that means that people are working together, right? When you're working in the same building, there's collaboration, there's communication, just knowing how to refer, that knowing that someone could come down the hall right now and refer is helps the patient, the client that walking in the door, certainly. Also increase screening that's happening in primary care. So there's a statistic that has a huge range, but it's essentially 30 to 60% of individuals walking into a health center accessing primary care really need to actually be connected to behavioral health services. So that means someone's walking in the primary care setting, and really the intervention that they need, or the help that they need, isn't available in a primary care setting. It's available in a behavioral health setting. So when you have screening that's happening, mental health and substance use screening in primary care, you can then actually screen for what the client needs and get them to the care that they need, as opposed to continuing to treat it as a primary care or physical health issue, and not having the appropriate intervention. So in our model, we have embedded behavioral health clinicians in all primary care settings. So they're there to provide screening and support to the providers, relationship building, and then most importantly, what's called a warm handoff, which that essentially is a transfer of care from one system like primary care to behavioral health or substance use that happens with a person, right? That doesn't happen with a piece of paper. Please call this 800 number. It happens with a person walking in. And that to me is where the real work of integration happens. So that means someone comes in for a primary care visit, or we're doing it in dental too, where someone walks into dental and they get screened for behavioral health and substance use screening. And so if it is positive, we have a conversation, we ask for permission, of course, if you would like to speak to a colleague that specializes this, and then a behavioral health clinician or substance use clinician literally walks into the exam room in primary care or in dental and meets and provides hope and support, and then navigation to services, which could mean literally walking them down the hallway to access treatment, which for those of you working in substance use, it's incredibly important, a point of insight or desire to get help, that there's intervention that happens immediately, because we've all experienced waking up and wanting an intention to do something and feeling ready to change, and then by Tuesday that maybe is not there anymore for lots of reasons, right? So we want to intervene as quickly as possible, and this is really the best case scenarios, to be able to have care in this way, and it happens when services are under one roof, when all services are available. And I want, we're talking, the conference today is centered on stigma as well. And I want to acknowledge that this model, to me, is the most destigmatizing model, because first of all, someone can walk in to the health center I'm at and they could be walking in for any appointment and doesn't matter, right? They don't have to disclose that. They're not walking into a sign that says, mental health services outside. They're walking into a health center, right? And also for us as health center administration and staff and providers to say that we provide all these services here means that we're acknowledging that these services are part of healthcare. We're not saying, oh, well, if you want substance use service, you have to go somewhere else, right? That sends a different message than saying we acknowledge that all of this is a part of health and well-being, and that people have struggles in their life, and there's help available, and it's here, and we want to be a part of the solution. And that is extremely important. I have provided countless warm handoffs as a therapist, and that is such an important message, to not send someone away, but to say that this is care that they can get here with providers in a space that they feel familiar with too. These are health centers, are in their community, they're familiar with the care and the people that are there. So, and then because, change doesn't happen overnight, there might be individuals that are not, certainly ready to engage in behavioral health services, and that's okay, because they'll come back for their primary care and dental visits and know that we're here too, and they know that they can access care in this way. So that to me is something that's working really, really well, and continues to be acknowledged in the healthcare system, that all these services should be provided and in a way that is easy for people to access them. Are there any questions about this, or anything that came to people's minds about, oh yeah, this is also working, that I didn't mention or reflect on, or someone else didn't? No?
I'm gonna be honest, like the reason why I decided to jump into this call is because I didn't really know the different avenues. Like I'm a third year at Sac State right now, in the graduate program. And so being at an intern at CCDS there on campus, like I've started to research more on other locations around Sacramento, so that way if I have a client that needs a higher level of care, like I've been finding locations, but I didn't realize that there was locations like this where it has it all in one area. So it's actually very knowledgeable, like it's opening my knowledge right now. So thank you.
Great, that's great. I want, as I talked and reflected about the things that have gone well, I want to acknowledge some of the challenges too, and we'll talk a little bit about that. But I'm sure if you've been in any integrated conferences before, conferences around integration access, they always show that image of the silos, right? I don't know if you've seen them, but they show the silos, and it's saying like, our healthcare systems are siloed in this way, and they are, and I could talk all day about the complications with them, certainly. But for me, it's more about like, it's the same house maybe, but different doors, right? So for me, it's about you could, even at our health center, right? There's different doors into access different services, but each house has its own set of rules, which comes with regulation, the way we bill, the compliance, right? And the way that services are delivered. And so it's become easier, right? Because if you have a bunch of doors, it's easier, the same location, but once you enter that house, it can be pretty different for the people that are hosting you in the way. And so I think that is one of the biggest areas of challenge. And I know Cal AIM is looking at how to adjust that. But that's one of the biggest challenges, is to get health centers or other organizations excited about doing an array of services, but then also not making it so cumbersome operationally to do that, because it is really challenging. It's the right thing to do, and with the regulations, it's pretty challenging. So what does true integration look like? Like when you're thinking about real integration, like services are there, like what do you picture? What comes to mind? I heard a comment, the comment earlier was around, case managers and staff working together and having good communication. Absolutely. What else do you think of when you think of good integration or true integration? Even if it's not happening, just like, what do you think of?
I guess, hi, my name is Kafila from Helpline Youth Counseling. I guess I would say that having some sort of or some version of all staff meetings where like information is given to everybody or distributed to everybody, and just so that everybody's on the same page. I would say that's a good component.
Yeah, so that you might have people working that have different disciplines, but they're getting access to the same information, right? And then there's opportunities for learning and communication. Absolutely. Yeah, great. What else? What else when you think about integration?
Hi, my name is May, and I'm a nurse practitioner, and I work mostly with pediatrics. That's my specialty. And mostly I came on because we have, with COVID, seen lots of families with addiction, and invariably that leads to homelessness, and we're dealing with a lot of challenges. I'm in Orange County, and we don't have a lot of access. And sometimes I do send patients to mental health. The only resource I have is like an 800 number.
Right.
And I guess for me, integration would be being able to call a mental health therapist or a specialty and actually give a warm handoff, where I don't have that option now.
Yeah, that's a great point. Ian was reflecting this morning about the mapping that we did in Yolo County, and I was a part of that process too. And the big gaps. So I think what the knee-jerk reaction sometimes when things are not going well is people will say there's not enough services, right? There's not enough, and that's all. Yes, I hear that all the time. Like there's not enough, and that's sometimes the case. But often, and we did this when we did the deep dive about mapping or for the criminal justice system, is that it's often how people get from point A to point B is the issue. It's, if you've ever sat in a meeting, and you hear about, I mean, even with Communicare, who's a big provider in Yolo County, there are people that have been in nonprofits that had no idea that we did, homeless outreach, right? Or, outreach for the unhoused. Like it's the way that services evolve, it's very difficult for everyone to always know. I mean, if you were to create a database, it would be outdated within 10 minutes of creating it, right? Of like resources, which you all maybe have experienced too in your communities. But it's not just about more, it's about how people get to them. So what you're talking about is navigation, which was exactly what the intercept mapping revealed, which was that we actually had a full wide array of services available for people, but people couldn't get from point A to point B because of all the barriers in people's lives, and also just how complicated our systems are and how people get access. And and so that led to me applying for a grant to provide, for example, navigators that are embedded at our local jail. So we're meeting with people and helping them get appointments when they're released from incarceration, and we drive them to the appointment. So it's not just saying, here, go to this building, talking to someone who has mental health and substance use challenges, who doesn't have transportation, who is living in stress and for lots of different reasons, and then asking them to get to appointment on time and find an address. It's pretty unrealistic for a lot of the folks. So we've been invested in looking at and investing in grants and time to look at actually just driving people and how much, if you think if someone shows up to an appointment and gets the care they need, how much it actually saves in an overall system and community, in addition to, of course, the impact on that person's life. So that's an excellent point, and something that's something that's incredibly important. So we try not to use the word referral, because referral is like, here's a piece of paper go follow up, right? And we've all received referrals for things, and you may or may not call them, or you find that piece of paper in your purse, like, years later, and say, oh my gosh, or we try to navigate them. We try to say, okay, well, this is your appointment. We're going to make an appointment, and then this is how are we going to get you there, and how, what barriers can we address in doing that? So thank you. Excellent point. Any other thoughts about true integration?
Hi,
Hey, Joe.
it's Joe again. I think on collaboration between the organizations, I know Dr. Quist and Ian were talking about collaboration with the police force. So just, collaboration between physicians, mental health practitioners, and, police department, I think is very, very important in terms of true integration. And also, I think with this collaboration, it'll break down the stigma that is heavily set with mental health.
Absolutely. So we're not just talking about integration of like-minded healthcare systems, but we're talking about all the systems that our clients in a community may or may not come in contact with. Absolutely. Great point. Any other ideas come to mind that anyone wants to share?
So there are folks sharing in the chat, and Teodora, Teodora is echoing the teamwork between people in saying that there should be consultation between different professional fields and access to information for a client. And then someone else said, I think assessment is super important to help the person address both mental and other oppressive factors that may be impacting them.
Absolutely. Absolutely. And just to piggyback on the comment about collaboration in terms of integration in multiple disciplines, I want to say it also needs to have a power leveling too. So if primary care is in charge of everything, right, and and sometimes you can see that in organizations or organizational charts where the CMO is in charge of other, I really challenge that, because I think that if we're really looking at integration and we're saying that primary care and behavioral health and substance use is all a part of health and one is not a priority over another, then we need to look at also the way our organizations are structured, because all of those messages happen, right? Whether they're subtle or explicit. And so it's something that I really push for organizations to think about, is who reports to who, and how is that sending a message about how we're all working together. We're just have different roles in the way that we work together. So some of those internal power dynamics can be addressed. Okay, great. I wanted to show this image, really old pictures, but I feel like it's helpful when I think about the way integration looks like through relationships. So, so what do you see in image A? If you think about this being a metaphor for integration of systems and people, what do you see and what don't you see?
I see two people doing the same thing. So say there's two different people helping the person, but they're not looking at the same picture per se, like the whole picture holistically. You know what I mean?
Yeah. So they're working side by side, right? This is, they're working side by side. They're doing the same thing, right? But what's different about picture A than picture B? What do you see in picture B that's different? And you alluded to it now, but any others?
So Heather in the chat is saying that she sees that the main person in the first picture is the adult and the child is a second role.
Yes, great observation. Yeah. Yeah. So you have people sitting side by side, but it does feel like there's a power dynamic, right? You can feel it in body language, they're both doing the same thing, but but it's different, right? They're reading out of different books. And so what's showing up in image B that is different, or what do you see that's different?
Oh, they're doing it together. This is Claudia.
Hi, Claudia.
They're working together, I think, there is an interaction.
Mm-hmm. Yeah, absolutely.
They're literally on the same page.
They are literally on the same page, metaphorically and literally. Yeah. So when we think about integration in relationships, it's really great when people are working side by side physically. That is a huge component because that builds relationship. We all have this in our life, exposure to people, we learn about people, we, learn who they are as a person, which helps, trust and relationships and referrals and all of that. I mean, we have that in our program that when if we have a physician that knows one of our behavioral health specialists really well, I'll look at the data and I'll go, why is there 99% of the referrals going to this person and not everyone else? And it really comes down to well, I know that person. I just knew that they were there. And I'll say, we have 14 other people that can be referred, but it's the relationship has been built, right? And so that's like the first step of integration. It's like, can we get people together that do different things, but can we get them together? But what happens in that process of integration, when we're thinking about like moving the needle, is that you may have people working side by side and that looks really good. And it is, I'm not dismissing that because it's a huge feat for a lot of people. But unless people are working and looking at the same situation or approaching the same problem, but with different lenses, that it's not really true integration. It's two people working side by side, which is good, which is progress. And I don't want to minimize that. And what our ideal would be is that there would be less of a power dynamic. I know I'm looking at, she's holding the book a little bit more than the other one, but that there would be, that we're all looking at the same situation and circumstances, but through different lenses. And so maybe as a behavioral health and substance use clinician, I will have a different lens on the situation that I can offer, right? And then a primary care, provider or a nurse practitioner will have a different lens. And so we're approaching each situation together with as a leveling of power and offering our experience. And that is the best interest for the client and the people that we're serving. Any other thoughts or reflections on this? Just a visual representation to see kind of the progress of integration and what we would like to strive for. Okay, great. So what is, I've reflected a little bit on this so far, but I just want to open it up. Like what's not working when you think about our systems and you think about, and you could think about this professionally, you could think about this personally. I know many of us have experienced these systems ourselves or our family members have. Like what is not working and what are the barriers? What do you see that needs to be changed? Or you've noticed it? You don't have to have a solution. You can just come with problems. Joe, did you want to say?
Yeah, so I think definitely for underserved populations, people of color, there's still be stigma of access to mental health, and it's not readily accepted in those communities. So I think that's one of the big barriers that's not working.
Absolutely. So culturally responsive services. I'll give an example. The county came to us, and in Yolo County, we have a big, very large Latinx population. And the county was looking at their data and saying that our Spanish-speaking community is really not accessing behavioral health services, and we don't know why. And there's lots of stigma and cultural considerations. And so what we did was we developed a team at Communicare of it's a mental health clinician, a case manager, and a promotora. And they are all bilingual and bicultural. So not just white people speaking Spanish, but they're bicultural, and they work in the community directly with the clients. And the engagement that we've had since that service has been created has been beyond our expectations in terms of engagement. And so it wasn't about looking at services and saying, oh, we just need to translate everything in Spanish, which was, some thoughts at the time, as maybe it's a language barrier, but really looking at the way that services are delivered by people that are living in the community with the cultural context being held, and being able to adapt and serve the community in the way that is most helpful. And so we really look to that team in terms of being able to decide what's helpful for the community and what people need. And it's been very, very effective. So more, that's just one small example in our county about the way that services really need to be delivered and tailored. So that's a great point, Joe. Thanks so much. What are other ideas about what's not working? I know there are problems. I know people have problems. Or examples of people that you've worked with that have challenges navigating systems or not getting access to systems, or your own personal life, or anything that that kind of surfaces for you about what's challenging in our mental health and substance use systems and accessing.
Hi, it's me again.
Thanks.
So I kind of mentioned earlier, my only access, like when I have a patient that is suicidal or has mental problems, or the family is dealing with homelessness or their own substance abuse, and I try to send them referrals, it's literally like an 800 number CalOptima paper that I give them. And then I like cross my fingers that they get accepted and triaged over. And then when I follow them up in a month, to make sure that they went to the services, sometimes they say, oh yeah, they gave me this medication, but then I have no access to what medication, because of course they didn't bring it or take a picture of it. So these things are, the fragmentation is like a huge problem in my specialty.
Huge issue, right? That, yeah, not knowing if, it's like cross your fingers, like I'm making a referral and hoping that happens and hoping they show up again so that I know that. Yeah, absolutely. This is my husband took this picture when I was in Iceland and we were lost, and I got out of the car and he took this picture, and I felt like, oh, this is like the perfect picture for like how people are sometimes navigating our systems and not understanding where to go and how to go and the language and even where to begin. And this was like, I said, this is the most unhelpful sign ever. And this is how I feel sometimes about the systems and the way that our clients are experiencing our systems. So some of the challenges, I don't know, it sounds like we have one provider here and a couple of providers. Are there other providers, people actually providing services in the field of mental health or substance use, whether through internship or whether through a role? It's so hard when you can't see everyone. I'm assuming that there's some of you who are here, but some of you may or may not know that in our specialty mental health systems and in drug Medi-Cal, our documentation standards are, it is astronomical what clinicians are asked to do and document in terms of compliance. And I know CalAIM is looking at that too. And the reason that I'm saying how important this is, and the reason why I put this first, is because if you think about a mental health clinician or a substance use clinician who's gone to school, who has expertise in serving, clients, and we want access to that service, and they're spending 40% of their time documenting, that's a huge problem for our access to mental health services, right? That is, imagine if every mental health clinician all of a sudden had 40% more capacity. And that's how I view it. I view it as like, this is actually taking away from people being able to provide care to the people that need it the most. And so I don't want to underestimate that this happens and how important it is for our systems to look at the documentation challenges and the compliance, because it really contributes to workforce. I also want to say, because I employ a lot of behavioral health and substance use clinicians, many. You saw I have over 100 person team. And the number one reason I hear of people wanting to move on to other, like for-profit settings or other settings, is not because of the clients. It's not because of the, the complex people that we serve and the fast pace and all the things that we might make assumptions about. It's almost always documentation. I didn't go to school for this. I don't want to spend all my time documenting and then told that I did it wrong and having to change it and the compliance. And so when we're talking about workforce, right? And I think there's a lot of data coming out and has been coming out through the state of California, looking at like, do we even have enough people in California to meet the demand or of the behavioral health needs in California? And I'm not sure we do. And I think it's going to grow. I think the result of this pandemic and seeing the the consequences of isolation and people not accessing services and all the things that I'm sure you are all aware of, we're seeing it in the data around opioid deaths and substance use and mental health challenges, and people that have never had mental health issues or having mental health symptoms for the very first time in their life in this context of the pandemic. So when you're thinking about all of that, and then thinking about that we have well-trained, capable providers spending a quarter, 40% of their time documenting. It's, to me, not something that is not working, and a huge problem. So I did want to share that. I've commented on this before, but we have a trifurcated system. We have, if you again think about the image that I showed about the 4 doors, right? That all of those, that's substance use services, that's mild to moderate mental health, that's specialty mental health, primary care, that it's all sort of split up. And so you have a lot of organizations that don't want to take on other services because they can't easily or administratively fold it into the services they're doing, because they essentially have to just start a new agency, but within the same roof. And some of you that are part of those agencies may know that, but it's very complicated. And then of course that's for people administering it. And then for people, to your point, the people that are navigating it, it's even more complicated. So they have to access substance use. They need to go to a county, but if that county contracts out the service, and they're going to another agency that provides the services. So it's complicated. And our system is split by severity of symptoms too. So you might be a child in the Medi-Cal system who needs behavioral health services, mental health services, but depending on the symptoms and the severity of your symptoms, you may access an entirely different system than your health plan, which is another system for people to navigate. So these are some things that are being addressed in Cali and looked at, but they are a problem with our system. And then, as Joe mentioned, I mean, the limited culturally responsive service delivery models, it's a huge problem in our field, and continues to be something that is incredibly important when you look at the data around disparities and the work that's happening. Is there needs to be more adaptation and more specifically culturally responsive services to the communities that need it in a way, and it being delivered in a way that they need it. And then workforce challenges, which I've commented on. So seeing this list, is there what am I missing? Is there anything that is that you think about that is missing from this, or does this spark any thoughts about other things that are challenging?
So in the chat, Ethan had commented that medicine for profit enterprise is a challenge.
Interesting. Is that, can you say more about, is that pharmaceuticals? Is that being like people being able to access certain medications?
Sure. I mean, it's a thread that complicates each of the things you mentioned. We don't have documentation standards because each for-profit entity that wants to make as much money with as much client base as possible won't share their data across systems. That's true even of the hospitals themselves, who are competing for patients and charging different rates for different types of service.
Yeah.
And so the fact that we as a country have decided to allow people to make money off of sickness and care is a compliment, is an umbrella factor for many of the complications that we talk about within the public realm, because these are the fallouts. These are the folks who didn't, achieve a status of job that has insurance. And so they have found them ways into a piecemeal public system that tries to fill in the gaps for those who haven't been economically worthy to have access to the healthcare system.
Yeah, absolutely. I mean, you're reflecting on such a big system challenge that it impacts everything. And I just want to comment on something specific about that, is that you also see it in the private sector, where, I mean, maybe many of you have experienced this. If you have the privilege of having commercial health insurance through an employer or your school, accessing behavioral health services is also not easy. And often there's a huge wait list, or you can go see someone that's, 45 minutes away, Saturday at 2 a.m. or whatever the opening is. And so it's just a challenge, and also the way the system is set up. And, you reflected in a for-profit system, where people sort of put their energy is based on profit. In the Medi-Cal system, it's different. It's certainly based on what can we do with the resources we have, and how to take care of people. And so I actually think a lot of that could be given, some of the learnings, and that could be given to the for-profit world, but without regulation in it, I don't think there's much incentive. So I think that's part. So great big problem you bring up that's really important to the context of this work, certainly. Any other comments or any other anything that else is missing from this slide when you think about what's not working in our systems? Okay. So I always like to end with some positive reflections and intention, and as you know, there's lots of room in CalAIM and at the state to provide feedback. And so I think it's important to think, if you're in the, if you're in the behavioral health field, the concept of a magic wand. Like, it's a classic therapist question about thinking about, if you had a magic wand, like what would be different? Not thinking about like how to adjust, certain elements to make it a realistic change, but when you're thinking about our system and how people would access in a perfect world. If you needed, like thinking about yourself, if you needed access to substance use treatment or mental health care, what elements and conditions would be there? Like, what would be a perfect way to do that, to receive care? How would that be for you? And you can just throw out ideas. It doesn't have to be just asking you off the cuff. It doesn't have to be a thought out 4-point plan, no PowerPoint. Just thinking about you in a moment of vulnerability and suffering, and wanting and getting to the point where you feel like you need and want care. How would that go for you in a perfect world?
For me, it'd be immediate access. I mean, I could be able to walk into a place and get immediate attention from a skilled clinician, and I have to, go through a referral system or see my primary care doctor, or, jump through hoops, and then also not be looked down upon, and that stigma wasn't there, and that absolutely, like Melissa said, less stigma, and obviously less paperwork, on both sides for us and the patient.
Yeah, I appreciate you commenting about the paperwork, even as someone that's coming in, right? So what you just described is walking in, asking for help, getting help. So not being told you have to go through here to get a referral, right? To get help immediately, and not being given a stack of paperwork to say, let me ask you 1,000 questions that you're going to then get asked again by someone else. And I also heard compassion, right? That it isn't about, that it's a destigmatized response. It's a compassionate response. Just like if you walked in and said, I think I broke my leg, right? And you're walking in, or you walk into a dental office and say, I have a toothache, right? It's rare that you would feel some kind of way about walking into a dentist's office saying your tooth hurts, right? You might have fear, you might not want to do it, but you certainly wouldn't anticipate that a dentist or a dental provider would have judgment about you. I mean, I know that there's judgment about flossing that dentists carry, but that's the dream of mental health and substance use, is that you would walk in and people would respond in a way that is routine, because it's not something that's special, or it was something that is a routine part of healthcare. So it's great. Thank you, Joe. Those are great comments. What else would be important when you think about yourself? And I'm asking you specifically to think about yourself, because it's important to personalize some of these experiences. Not thinking about someone else or a friend or a client, but thinking about you. You're in this situation, and you might have been, and you may be. What would need to happen in a perfect world?
Sarah, in the chat, Melissa had said less stigma, more clinics, less paperwork, what you and Joe were speaking to.
Sure.
And Heather said that someone I trust, speaks my language, understands my culture, can help me.
Absolutely. Those are great things. Understanding the feeling trust and connection, being able to communicate in the language that you feel comfortable with, someone that understands the context of the situation that you're in, or can learn that, or you feel trust in. Absolutely. Those are great. Yeah, great points. So I think you said something in the chat about more clinics. And so I also want to comment on that's an element to this too, about you being able to go to a place that's convenient, right? That you don't have to drive or take multiple buses to get to a place just to find out if you need care. And so And so now people are obviously, for us are getting care in person, but they're also getting care through telehealth, which for some has been really convenient, and for some it is not. It's not helpful, and so we're trying to do a hybrid and figure out what people need. So those are really, really great. Any others that you think about? Again, thinking about yourself, what would be important to you?
In the chat, May had said a safe and clean place.
Yes, that's really important. So place, the environment in which you're being served, right? That shows respect, feels inclusive, feels safe, a place that is, there's a lot of attention, especially in the trauma-informed care clinics, thinking about how to create a trauma-informed space where people feel, yes, absolutely, that's a great comment to make, that it's a place that you feel good about coming and you feel respected when you're there based on the environment. Great. Any other thoughts about it that come to mind?
Hi, this is Heather. Is it okay to just, I'm not sure about the parameters. Can I say it out loud?
You can. You absolutely can.
Okay. I think the other thing is that, if I am not able to get immediate access, that the providers are able to articulate to me what happens next, right? So how long am I going to wait? What are the steps? It oftentimes seems like it's because the system is so challenging that they're unable to make those statements, and then I'm sort of leaving in this state of even more angst, right? More concern, more worry. So even if I can't get direct care access, making sure I'm clear about what the follow-up is.
Absolutely. Great point. That's also trauma-informed, actually, initiative is to say what's going to happen, walk someone through it. That was, even that couples kind of in the comments earlier about navigation, like we're not just saying someone will call you, Heather, right? And you wonder whether that is today. I mean, you need help, right? And so when will help be there, right? So being able to have systems that have enough time to slow down, to make sure that people know exactly what to expect and when to expect it, even if they can't provide care in that moment. That's a really, really important nuance. That's extremely important. Thank you for that. Any other thoughts or that come to mind? Okay, so I encourage this activity in your own life, in your profession, and reflecting on what would be most helpful to you and thinking about that. We obviously are in this field because we care and have empathy for others, but I think it's always important to come back and think about ourselves walking through these systems and what we would expect and what we would tolerate and not tolerate, so that we can do better, and we can make adjustments, because all of you will be a part of some sort of system that you can influence and make adjustments, whether it's big policy decisions that need to happen and regulations, to even what feels like minor adjustments that happen in clinic flows or services that really make a difference in people's lives. So thank you for allowing me to be here and engaging. I really appreciate all the comments and considerations. We have, I think, a couple more minutes if there's any last questions, or if Carly wants to wrap up, but thank you so much. So Carly, I don't know if there's any in the chat, or I'm happy to answer any questions, or just that's.
Nothing in the chat, just the thank you from May right now.
Okay.
Yeah.
Okay, great. Well, thank you everyone for being there. My contact's here up if you have any further questions. Nice to see you, Joe. Hope you're managing okay with your child. I have 2 young kids in distance learning, and I know that's a lot. So thanks for being on camera, and thanks for all being here and engaging in this important topic.
Thank you.
Enjoy the rest of the conference.
Thank you.